Hello, LinkedIn. Welcome to our fireside chat on digital enablement within NHS. My name is Natasha Bradley from Empower M365, and I'm really excited to be joined by John Mitchell, Associate Director of Digital at the NHS Humber and North Yorkshire ICB. John, could you just give a little bit of introduction, please?
Absolutely. Thanks, and hi everyone. So I've been in NHS digital kind of realm for about 27 years now. So when I first came into it, it was a very emerging and very different environment to what it is now. So I've seen a considerable amount of change, and I've also really seen our profession really adopt a level of professionalism which wasn't there kind of years ago. And I think that's a real positive thing. Tend to work on large scale programs, things like share care records, one of my key preferences. But over the years, I've turned my hand to quite a lot of IT and digital pieces of work.
Perfect. Thanks, John. So, John, in a world of rapid technical change, and obviously the NHS going through so much change at the moment, how do you decide from a technology perspective what trends to follow and which ones to actually ignore?
Yeah. Okay. So there is a question that I ask whenever we are looking to deploy or research or whatever any kind of program, and that's so what. So if we start to go down this path, what will the benefits be? What will the change be to the professionals and to the public? And what will the overall impact, both positive and negative, be? So what? We do this, and so what? And that just really helps make sure that I understand what we're doing. But by asking that question of the people around me, it ensures that we've done some level of due diligence about it being the right thing to do. Have we asked the right questions of the right people at the right time to make sure that the process is going to be empowered to be able to be successful? Okay, so that's whenever we see something, first question, so what? So is it solving a real problem? Are we doing it because it's trendy, or are we doing it because it's going to make a world of difference? Is it something that we can scale? Is it going to be sustainable? So have we just been given a year's worth of capital so we can only afford to do it for 1 year? Or is it genuinely going to start paying for itself and become sustainable when we need it to be? Is there an evidence base of success? And I mean genuine evidence, not a supplier written use case. So is there an evidence base that we can go and we can evidence to say, yes, this has made a positive difference. And if we do this in this way, actually, it's going to be good. It's going to be okay. Are there lessons learned? Is there a lessons learned base we can go and make sure that we can follow? Can we align it to our strategy? Does it align to our governance? And is there a good alignment to our organization or our system priorities? Because if there isn't, why are we doing it? Okay. Is it a system which we can support? Is it a solution that we can support? Is it going to be used, or is it just going to get left on the shelf unsupported? And there's been examples over the years, both positive and negative, where we do things in the right way, it really works, and then other times where it doesn't. So if you look at things like when we first started to look at mobile enabled devices for mobile clinicians, okay,
Yeah,
we didn't particularly really start to understand the use case. We were just convinced it was going to work because it was going to be the right thing to do. So we perhaps ignored some of the evidence base that was around, some of the use case, and perhaps we didn't do some of the user research and engagement in a way which we would now. And actually, a lot of those mobile devices just got left in the drawers because it was trendy. It wasn't really, we didn't have the evidence base. We didn't do the business change that was required. Okay, and we kind of learned from that, and then we went on. And if you look like things like AI, kind of a real hot topic at the moment for all the obvious reasons. We can see there is an emerging evidence base, but is it quite there yet? Is there a way where you can turn efficiency into cash releasing so it becomes affordable? And is there evidence base there? That's still up for debate. Clearly, there are some benefits there. If you just deploy it randomly, then actually it becomes quite an expensive, trendy tool. So you need to make sure that you understand which use case. Sometimes trends are driven by requirement. So during COVID, we kind of rapidly deployed video consultations because people
Yeah.
couldn't travel. And suddenly the use case for those, the trend behind them was really urgent. And in some regards, it was almost seen as life and death. So we need to protect our frontline clinicians from COVID, and it was well adopted and it was well used. As soon as the use case went away, so people could start traveling again, the utilization of video consultations rapidly dropped. So just because something fits at one point in time doesn't necessarily mean that it's going to fit going forward. So it's
Yeah.
important to understand how long that trend and requirement is going to be fit for. But when you get something right, so kind of share care records, integration across systems, um, Microsoft Teams is a fantastic example of where something has stuck around and made a positive difference. Number of miles traveled has reduced, etc. When you get the right use case, of which there's a couple of examples, and it makes a difference, people are bought in, people see the benefit and directly feel the benefit, then actually it starts to work and everyone sees the benefit. So trends is an interesting and complex word. It's around what that driver is. Is that trend a driver?
No, I think that's a great explanation of why and the questions you go through, which all makes sort of sense. But how do you balance that sort of drive for innovation with inclusivity when adopting new technologies?
Yeah. Okay. So inclusivity is an interesting challenge because it covers many fields. So
Yeah,
the natural assumption is when we talk about inclusivity, we're talking about digital inclusion. Okay,
yeah,
so are we excluding people? People do not have the digital maturity, whether it be staff or patients, to be able to utilize the equipment which we're deploying or the solutions that we're deploying to be able to see the benefit, or are we making their life worse? Okay, and that's something that we need to look at. So we need to look at the business change, the support. Sometimes this is a lot deeper than people can realize. So you could have in an environment people who are completely digitally mature within the environment of which they're currently trying to use. Okay.
yeah,
And then as soon as you change something, it becomes new to them and they lose that digital maturity. And so have we then factored in a drop and then that initial drop in digital maturity into the plan, or have we just assumed that everybody who's okay at the moment will continue to be okay? It doesn't matter what kind of field you're in, whether you're talking about staff, whether you're talking about patient-facing services. Um, it's important that we understand that change is change and change needs to be managed. So we can make assumptions around, okay, we know that anybody in this demographic is going to struggle, but have we made the right assumptions around those who we assume are in the right demographics? And have we really done our user-based research, our user-based design to make sure that not only are we looking to improve the inclusivity, but we're not hindering anything, even if it's only in the short term. Can we manage that gap? Because if we don't get that right and people become disillusioned on day one, they lose the confidence and it becomes much more difficult to actually get it back. So there is really something around understanding your user base there. Need to make sure
yeah.
that
And I think
whatever
that's
we
a
do,
great.
sorry, go on.
I think it's a great point, and I think that many people miss that.
Yeah, there is just one extra point to that though, is that
Yeah,
sometimes you need to accept that something that you're putting in will cause some level of inequality for others. and
Yeah.
some of the primary care systems, that the public facing stuff. But if you can improve the efficiency in the system by making a change, then it may free up the resource and the ability to then support that 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 cohort of users who can't or won't be able to use the system. So sometimes it's definitely not about one size fits all. Sometimes you can need to recognize that a change is a positive change, but then you still need to go back and make sure you're supporting those who are excluded by that change. And that change may allow you to do that.
Yeah, no, good point. And it sort of reminded me of a conversation. Someone not in the sort of NHS space, but they were sort of saying about making sure users are inclusive when they're rolling out things like Copilot for M365, because most of organizations are only rolling out small amounts at a time. How do they get making sure that everyone's inclusive of driving efficiencies being enabled by technology? And I think it's a real good point to sort of touch upon there as you answered that. So it's a really good point.
Okay.
So
Yep.
so in terms of digital enablement, like for frontline workers, let's bring it back to the NHS. How do you think we can better support them?
So this is kind of a multi-pronged answer, really. So apologies if I waffle in advance. So people need to understand the benefit. People need to see the evidence, of that benefit, and then people need to benefit from the benefit. So whenever we put in something new, what is that benefit? What's that selling point that's really going to make that person's life easier? Because ultimately, that's what we want to do. We want to make someone's life easier, whether that's efficiency, whether that's simplicity, that's whether they're able to do more in the same amount of time, doing things they've never been able to do before. We want to make their life better. So, is what we're adding going to add value, or is it going to add burden? Okay, first
Yeah,
first first question. And sometimes organizational value is different can create personal burden, and we just need to kind of understand that.
yeah,
Yeah, is it easy to use? Does it fit into pathways? Does it fit into workflow? Are we keeping people within a focus, or are we asking them to jump around? Are we disrupting their process of work? Does it allow them to work in completely different ways which meet the requirements of the organization around them, or is it putting them at odds? So, if an organization is becoming agile in its working style, will the new solution, whatever we're putting in, will that make the uh, worker fit into that agile work style, or are we keeping them in the past, or are we moving them down two different chains? It's important to understand that. And you won't necessarily understand that if you don't engage with the users. So are we co-designing a solution with the staff in mind? Okay. Are we doing something to somebody, or are we working with them on something? So we aren't giving them a Christmas present here. What we're doing is we are working with them in partnership to make their lives better, which I'm sure
yeah,
will be much more appreciated than a Christmas present, certainly in the long term. How as we deploy, how we support him. How do we define the as is and the to be, and how do we support them get from the start to the end of the journey? How do we make sure we don't just drop them in at the deep end without any support? How do they get the encouragement and the confidence to understand that what we're doing here is for the best? And it's okay to make mistakes, and there will be people with them there to help them through those mistakes and those difficulties. Some of the solutions we put in are complex, and they have to be complex. And it's okay that people will need help and advice and guidance. There are very few systems that we can just drop on someone's desk and tell them to get on with it, even for the most digitally mature members of staff. So real-time support, make sure they can feedback, make sure we can tell them what we think. Do we need to have another loop of design? So after we've deployed, does it work, or are there changes that we can make to the overall process? So it's not something that just happens once, it's an iterative process to kind of get to the right point. Um, And how are we making sure we've got support for confidence? With most things digital, confidence is so important.
Yeah.
And do we need champions? Do we need peer support? Do we need to make sure we've got the right sort of training? Is that training face to face? Is it bite size online? Um, and how do we recognise formally the the job well done after someone's made the change? Because how many changes have we all gone through, and that's the expectation, and then no one said, well done. That was difficult, and you've got through, and you've done well.
Yeah.
And so I just think there's the whole package there, and support, recognition, um, confidence. Start to wrap it all up together, and then we start to really enable. If we don't tick all those boxes, then we're in real risk of hindrance, and that's where we want to. That's where we don't want to be.
Yeah, no, agree with that. One of the words that you mentioned was burden. So,
Hmm.
with many digital health tools emerging, how do you evaluate them, taking into consideration not burdening people, but making sure that they are clinically effective and operationally sustainable?
Yes. So, are we providing a piece of the jigsaw,
Hmm.
or are we trying to use a hammer to fit a picture into something which doesn't really fit there? Okay,
Yeah.
and that's a question that we need to ask ourselves. So, clinical and operational effectiveness. Okay, what's evidence? Has it been peer reviewed? Is a clinical endorsement? Is this something that IT is doing to people, or has somebody who really genuinely understands the benefit to the end user, in our case often the patient, have they said, yes, this will work and we can validate your use case for this? Okay, you will generate a business benefit, a personal benefit, a health benefit, a benefit of some sort, and we will be able to validate this. That's kind
Yeah.
of really quite important. um, so clinical evidence, let's in our world.
Yeah.
um, does it operationally work? So perhaps linking back into our trend conversation,
Hmm.
AI is quite an interesting hot topic at the
Yeah.
moment. Are people investing in solutions or taking free trials of solutions of something which fits on the side, or does it integrate safely and securely into an operational environment? Is it interoperable? Does it interface? Does it Is it easy to use? Does it reduce the amount of mouse clicks that you need to make in order to get the same or a better uh, result? And yeah, that's another kind of need to fit. That operational fit is absolutely key, making life easier. What's the return on investment? Okay, ultimately, somebody will ask us, it's going to cost us this upfront, it's going to cost us this every year, both pay and non-pay costs.
Yeah.
What's the outcome for that? Is that outcome measurable in terms of benefit? Is it measurable in terms of cash releasing savings? Is it
Hmm.
measurable in terms of clinical pathways? So we're seeing less people going through a pathway. So how do we generally understand, and how can then we evidence the return on investment which is made? Because a lot of the solutions we invest in, we aren't talking about £1 or £2. If you look at
No.
how much money has been invested rightly through the frontline digitization program in terms
Hmm.
of ensuring that all trusts have some form of um, secure EPR, then we're talking a lot of money. And how do we then make sure that we can measure that return on investment? Um, and sometimes going big bang doesn't work. So milestones,
Yep.
start small, learn fast, scale wisely. Can we start to answer that so what question better if the pace that we are working at is manageable, so that we start to build the evidence base to then fit that into further conversations?
Yeah.
So sometimes, I guess that's the old traditional pilot point of view, isn't it?
It
Like
is.
to think we kind of like to think we're in kind of the educated pilot stage now. Um, Start small, learn, reinvest. Um, Programs are circles, they're loops, they're not big bang. It's an evolution. So if you can start to answer all those and learn whilst you're doing it, then you're probably going to be in a better place than if you just buy something off the shelf because it's trendy.
Yeah, and I think having that evolutional sort of business improvement style will help moving forward into like Copilot M365 or any other AI tool, because that's the way it's sort of going, as that evergreen of improvement.
Yep.
So John, if you can share one story with us where sort of digital transformation significantly improved either the patient outcome or staff experience, which story would you like to share with us?
Right. Okay. So I'm going to share the story of we were the first area to integrate directly EMIS and System One. So
Amazing.
our two primary care systems, and this was some time ago now.
Yeah.
So some of the benefits I'm going to talk about now don't see that great, but back then
Mhm.
it was quite a big thing because it was pre share care records
Yeah.
really. Okay, so two main primary care systems, EMIS and System One. EMIS was also the um, community system of choice, generally mental health system of choice, hospice system. We had quite a bit of System One usage, but quite a lot of EMIS GPs who kind of still use the system, and those systems did not talk to each other. And some of the consequences of that were if you were an EMIS GP but your community staff were on System One,
Hmm.
then you couldn't see those records. If
Yeah.
you were working in GP out of hours, but the patient in front of you was their main GP was based on EMIS, then GP out of hours really couldn't see the information about the patient. Kind of makes you wonder how we managed to work back then, really.
Yeah. It does.
Um, if you were a hospice, then you're on System One, you couldn't see the patients, residents, service users, EMIS records.
Yeah.
So that was quite a big problem, and we needed to understand why we're doing it. We went and we talked around our clinicians. We understood the day-to-day challenges that they were facing, and we had to explain some questions along the lines of, well, why can't you move our community staff onto EMIS and stuff like that. So we had to try and control the narrative around the overall value of change, not just the change to each individual units. And we had to work with two partners who were competitors across the marketplace, which and there was a great deal of professionalism there. Not, there isn't any secret skeletons in the closet there. They were all professional at all times. But fundamentally these are competitors in the marketplace, and perhaps if that wasn't the case, things might have happened in a slightly different way. We had to run the program in a very formal manner. Okay, kind of formal documented minutes, very structured action logs, checking up regularly to make sure that happens. Um, all manually documented because this is before Copilot. Um, and working with our user groups, understanding the technical challenges which need to happen, working with them to understand through user testing acceptance where the data quality was wrong or the system wasn't working properly, and then working back with both suppliers in order to work through, and then making sure, really importantly, that we had the governance in place to be able to support the sharing that we wanted to do. I think everybody agreed it was a good idea, but that doesn't mean that you can bypass some of that IG and security stuff which we needed to do. And we needed to make sure that there was always a valid reason why a non-GP would be able to see a broader record. And so we needed to make sure
Yeah.
we had the right process to make sure that there was a valid referral in place, as an example, or it was effectively an walk-in clinic. And when we got that right, overnight, across the entire of our system, we're suddenly able to provide system one users with that EMIS record, okay, and vice versa. So if a patient walked into GP out of hours and they were from an EMIS practice, suddenly they were able to get the right empowerment in place to be able to help that
Yeah,
patient.
amazing. Yeah.
Community records were now shared with EMIS GPs, and hospices could now see all records. That was literally an overnight switch on, but there's an awful lot of engagement before that. There's a lot of confidence building, because you have to reassure GPs who are the data controller that, well, actually, no, this is safe, this is sound, this is valid, that there has to be a legitimate reason for a record to be viewed. Okay, and when that concept is still quite a novelty, because we're like talking
Mhm.
several years ago, that's quite a
Yeah.
difficult conversation. Um, but it's a truly collaborative experience. We can manage that central sharing. The other thing that we did alongside that was we started activating system one to system one centrally managed sharing. So as patients moved around our system, they came in touch with other system one units. Rather than have sharing have to be set up patient by patient across all those units, we put in a centralized managed list which GPs could activate, saved them lots of time, and it meant that patients could now have their records viewed across system one in the right place at the right time by the right person. And by
Yeah.
putting those together, actually, the benefits were really easy to articulate, and the whole narrative around the piece of work um, was really clear and straightforward. There was no smoke and mirrors. It was all logical. It was all evidence based. We were able to take people on that journey with us, and they understood the benefits to themselves and the benefits to the patients.
Suppose it's going back to that sort of first sort of conversation we had about the so what. You go through the so what scenario to ensure, that journey
Yeah,
is fulfilled, which
that is
is,
that really is one of the most powerful weapons in my arsenal. Is that question? So
yeah,
what?
so what,
Whenever
yeah.
whenever it comes to you, can you define the so what? And if they answer it the first time, ask them it again. It's almost like the 5 why principles. Ask
Yeah.
somebody 5 times why they're doing it, and they might eventually get down to the real answer. And so, yeah, so what? It's could become kind of a mantra to me, and
Yeah.
my team quote it back to me often.
I bet they do. And it just goes to show, just in our sort of short sort of half an hour conversation, of how that so what is taking you from, understanding emerging technologies through to delivering a really digital transformation, which is significant value to both patients, but also from a user staff experience.
Yeah, I've got another so what just to
Yeah,
share with
brilliant.
you
Yeah, great.
along the same lines. So one of the pathways that came across our desk a few years ago was the end of life pathway.
Yeah.
Okay, and particularly those patients that had an EPAX record.
Hmm.
So last 12 months of the life, just starting to plan and capture that patient's preferences. The idea is that they get a say and a voice throughout the entire of the most difficult of pathways. Okay,
Yeah.
and there were challenges with the process. So at that time, the only people who could update the patient's preferences were the GP. So the GP would enter the preferences into the uh, primary care EPR, and then it become available the next day through the summary care record, which was
Yeah.
a national solution. Um, Patients change, particularly to what patients can change their
Change.
day several times. If they're not with a GP, that means that whoever the care practitioner was with them had to phone the GP and get them to update the records. Okay, now that wasn't always in real time. Let's forget that kind of somebody get a record updated overnight. Sometimes, if you got remember a practitioner who's seeing 12 people in a day, sometimes they'll do patch them all together 12 at once. That's nobody's fault. That's how the system was. So we put in a system which allowed anybody involved in a person's end of life care to be able to update the patient's preferences and life preferences in real time, and then it would be shared through EPRs and also through our share care record, the fantastic Yorkshire Number Care record, as changes were made. And that really did give the patient a voice right through the entire of that pathway, even beyond the point where they wouldn't normally be able to have one. And the best way I can evidence that is across our patch, the percentage of patients who now die in hospital who have an EPACS plan, okay, has dropped from over 40% down to 14%.
Wow, that's incredible, John.
And there is, there are some times when a patient's preferences need to be taken into consideration, but then a different outcome. But just being able to say we can now give a voice to those patient preferences right through. It's in real time. It's shared everywhere it needs to be shared. I think that really just kind of shows understanding that. So what?
Yeah, it definitely does. It definitely does. That's a great one to highlight. So before we finish, is there any other so what you'd like to share with us?
So before we finish, I think it's important just to kind of recognise that our profession is no longer emerging.
Yeah.
We are kind of a staple. We are no longer the IT crowd from like the TV show. We are a whole profession in our own right, and we need to be integrated into every discussion right from day one, because we are the enabler. Now, one of the areas we are struggling in is that we are really struggling with that next generation. Okay.
Yeah.
So how do we make this profession attractive? How do we then secure, encourage, and bring through our emerging leaders? And we need to make sure that our emerging leaders feel comfortable to get themselves and embed themselves into the same conversations that we do. Otherwise, they won't be able to learn. That they are empowered to be able to challenge. So if they, because they've got a fresh pair of eyes, they've got different ways of working. Honestly, the new generation coming through have very different work styles to us. They see things differently. They need to be empowered to be able to challenge the status quo. They need to be able to change the voice in the room. And I think as existing leaders, we really need to get our heads around this really quickly. Actually, our profession needs to find a way of encouraging the next generation of leaders to come through, whilst there's still kind of a supporting arrangement in place to be able to empower them to do that. Otherwise, what we're going to start to see, and this year is going to be a great example of that.
Yeah.
The number of existing leaders in place will start to drop, and we'll start to have gaps and knowledge gaps and confidence gaps. And we need to make sure that we control the evolution of our profession rather than we are in a reactive state. And so that's kind of a plea. Yeah, emerging leaders, challenge us, push. You've got the empowerment. Existing leaders, support them to kind of do that, please.
Yeah, I think it's a really good place to finish on. I don't know if within this sort of NHS you've heard of reverse mentoring. I've seen it across corporate organisations that seems to be successful to fill that gap where they have sort of upcoming leaders mentoring the C-level stakeholders within organisations. And I think that's something really to look at. And if there's a shout out to some of the organisations that are already doing it, but it's a good place to start if you're not, to really start bringing those leaders through.
Indeed. Thank you.
John, thank you so much for your time. It's been wonderful to chat to you. LinkedIn, thanks very much for joining. If you have any questions, please feel free to contact me. But I will see you again shortly. Thanks ever so much, John. Thanks, everyone. Take care. Bye-bye.